Our goal here is pretty simple. We take complex, dense source material, strip away all the noise, and just leave you with the essential knowledge you need. And today, we are undertaking a really complex, but I think fundamentally essential deep dive. We're going into the pharmacology of the central nervous system, specifically focusing on anti-epileptic drugs, or AEDs. Our sources lay out really a century of drug development, from these, old classic molecules to modern targeted treatments. So our mission today is to get a truly nuanced understanding of how these drugs try to control the unpredictable nature of epilepsy.
Yeah, and that unpredictability is the core challenge.
Right. We're defining the problem as treating, and this is the technical term, paroxysmal cerebral dysrhythmia.
Which is really just a fancy way of saying sudden disorderly electrical activity in the brain.
Exactly. And this activity shows up as in, sensory episodes, psychiatric phenomena, or sometimes loss of consciousness with those characteristic body movements we call convulsions.
And the key, as you said, is the unpredictability. Patients don't know when an attack is coming, and that's what makes a normal life so difficult.
To give you a bit of a historical anchor point here, this isn't a new problem. Over a century ago, J.H. Jackson described it as a disease of lightning.
That's such a powerful image, isn't it?
It really is. It captures that sudden, chaotic nature perfectly.
Yeah.
Our job today is to show you how pharmacological science has evolved from just trying to suppress that lightning to really understanding the circuits that produce it.
Right.
So we're setting the scope. We're tackling the core categories of AEDs, moving from the classic sodium channel blockers, which, they came with some brutal kinetic complexities.
Oh, absolutely.
And then we'll move to the newest generation, which offer, astonishing specificity and much cleaner profiles. We really need to focus on their specific mechanisms, their kinetics, and why those details matter so much clinically.
That framing is essential. If you were to summarize the whole goal here, it's this. Treating epilepsy is not about curing the disease.
Right. Not a cure.
It's about suppressing the seizures. The goal, if possible, is total control, so the patient can live a completely normal life. And that requires just a deep, deep understanding of how we classify these events in the first place.
Okay, so let's start with that blueprint. We'll begin with those classic pillars, right? The older drugs.
Yes. Things derived from barbiturates like phenytoin and carbamazepine. They mostly rely on blocking sodium channels.
Then we'll look at the more focused agents, like, say, ethosuximide for absence seizures.
And then we can explore the real revolution brought by the newer drugs. Things like levetiracetam to Paramedical. They use totally different mechanisms, targeting different receptors or even synaptic machinery.
Okay, let's unpack this then and start at the root of the problem.
Yeah.
The neurology. Before we can even talk about drugs, we have to classify the event.
Absolutely.
The entire decision tree for therapy seems to hinge on one fundamental difference. Is the seizure generalized or is it partial?
Precisely. And when we talk about generalized seizures, what we mean is that the event starts diffusely. It rapidly involves neuronal networks in both hemispheres of the brain, right from the start.
So an EEG, an electroencephalogram, would show abnormalities on both sides immediately.
Immediately. There's no single starting point you can pinpoint.
Let's start with the most dramatic presentation, the generalized tonic-clonic seizure, or GTCS. Historically, this was called major epilepsy or grand mal.
Right. If you've seen a seizure portrayed in a movie, it's almost always this type. They're visually dramatic, and they typically last 1 to 3 minutes.
And there's a very defined sequence of events.
A very clear sequence.
Yep.
Often there's an aura beforehand, then that distinctive epileptic cry as air is forced out of the lungs.
Followed by the loss of consciousness.
Yep. Then you get the tonic phase, which is that rigid, sustained contraction of all the muscles. And that's followed by the clonic phase, the rhythmic, symmetrical jerking.
And then, after all that, the sources say the episode resolves into a period of deep, what they call post-ictal sleep.
Exactly. The brain is just exhausted from that massive electrical output. And often what triggers this kind of seizure are things that depress CNS function or cause excitability, like severe sleep deprivation, high fever, or metabolic issues.
Okay, so contrast that really dramatic event with absence seizures. The old minor epilepsy or petit bone.
A whole different ballgame. These are very common in children, and they are startlingly brief, maybe half a minute. They're subtle.
Subtlety's the key word, isn't it?
It is. There's no big tonic-clonic muscle component. The person might not even fall. They just seem to be staring into space, maybe with a little bit of blinking or minor jerking.
So a child could be having dozens of these a day, and a parent might not even realize they're seizures.
That happens all the time. And the definitive diagnostic tool here is the EEG.
Because it has that unique pattern.
A very specific defining pattern.
Mm-hmm.
A rhythmic, symmetrical 3 cycles per second spike and wave. It's so regular, which tells you the mechanism is very different from the disorganized chaos of a GTCS.
Okay, moving through the other generalized types. We have myoclonic seizures.
Right, and these are basically just sudden, momentary jolts, a quick contraction of muscles in a limb or even the whole body.
And they can happen on their own.
They can, but they often accompany other types of seizures, suggesting a sort of generalized tendency toward this sudden muscle firing.
And then you have the complete opposite effect with atonic seizures or akinetic epilepsy.
Yes, here the patient just suddenly collapses. It's a brief, total loss of muscle tone. All the muscles just relax.
So instead of an electrical storm causing muscles to fire, it's causing them to stop firing.
That's the theory. An excessive inhibitory discharge. It's like the off switch gets flipped for the entire postural system, leading to what's called a drop attack.
And lastly, in this category, we have to mention infantile spasms or hypsarrhythmia.
These are seen in infants, as the name suggests. They're very worrisome because they're often linked to underlying severe brain damage and can lead to progressive mental deterioration.
And the EEG is chaotic here too, right?
Completely chaotic, high amplitude, irregular waves. The diffuse nature of the brain damage makes this an incredibly difficult form of epilepsy to treat.
Understood. Okay, so that covers the diffuse bilateral seizures. Now let's pivot to the second major category, partial seizures, which have a localized focal origin.
Right. Partial seizures start in one specific identifiable area of the brain. You might be able to detect that focal point from the patient's description of their symptoms or with a localized EEG reading.
And the key is that this activity can stay local or it can spread.
Exactly. Which brings us to the first type, simple partial seizures, or SPS. The defining feature here is that the patient is aware during the attack.
So consciousness is intact.
Completely intact. The symptoms just reflect where in the brain the seizure is happening. If it's in the motor cortex, they'll get unilateral jerking. If it's in the sensory cortex, they might feel pins and needles.
Visual cortex, visual hallucinations. Makes sense.
Right. The electrical activity stays contained enough that consciousness isn't disturbed.
Now compare that to complex partial seizures, CPS, which are often tied to the temporal lobe.
CPS is where things get complex. The seizure activity disrupts areas that govern memory and behavior. This leads to what's called a psychomotor attack.
Bizarre and purposeless behaviors, automatisms like lip smacking.
A dreamlike state, emotional changes. It can last for a minute or two, but the key factor, the defining factor, is that the patient has no recollection of the attack afterwards.
So the electrical activity spreads just enough to interfere with conscious function.
But not necessarily to the whole brain. Not yet, anyway.
Which perfectly leads into the third type, which links the two big categories. Secondarily generalized seizures.
This is when a simple or complex partial seizure starts, but that focal electrical discharge just takes off. It recruits surrounding networks and spreads until it involves both hemispheres.
And culminates in a full-blown, generalized tonic-clonic seizure.
Exactly. And that's a critical distinction for treatment, because you need a drug that can handle both the focal origin and the generalized chaos that follows.
Okay, now that we have a firm grasp on the clinical targets, let's get into the pharmacology. And what's so fascinating is how these older classic AEDs, they were powerful, but they were a real beast for clinicians to handle.
A huge learning curve. And it's because of their highly volatile pharmacokinetic profiles, even though many of them shared the same primary mechanism.
That mechanism being, for the most part, sodium channel inactivation. And the poster child for this complexity has to be phenytoin.
Oh, phenytoin. It's the standard, but it is a difficult standard. Its story is actually pretty interesting. It was synthesized way back in 1908 as an analog of phenobarbital.
But it was shelved, right?
It was, because it lacked the sedative properties of barbiturates, which they saw as a failure at the time. It wasn't until 1938 that it was specifically tested in an electroshock seizure model, and they discovered its profound, non-sedating anticonvulsant activity.
A groundbreaking discovery. Let's dig into that mechanism. What does it mean to prolong sodium channel inactivation?
Okay, so the core idea is to prevent that runaway firing, that repetitive detonation of neurons that leads to a seizure. A neuron fires using voltage-sensitive sodium channels.
Right.
After a channel opens and lets sodium in, it enters an inactivated state. It can't open again until the neuron fully resets. Phenytoin's main job is to bind to the channel in that inactivated state and hold it there for longer.
So it's not blocking the channel, it's just extending the mandatory rest period.
Precisely. By prolonging that inactivated state, it increases the refractory period. This means it's really good at suppressing the high-frequency discharges you see in seizures, but it has very little effect on the normal, low-frequency firing the brain needs for everyday function.
Which is why it's not super sedating at therapeutic doses.
Exactly. Now, the sources do mention some secondary actions like depressing glutamate release or facilitating GABA, but they also stress that those effects are probably uncertain and only happen at near toxic concentrations.
Okay, now let's confront the beast. The pharmacokinetics. Why is dosing phenytoin so notoriously difficult?
It all comes down to its metabolism. First, its oral absorption is slow and kind of unreliable because it doesn't dissolve well in water. But the crucial detail, the one you absolutely have to remember, is that its metabolism is capacity limited.
Explain that concept again. Most drugs have a predictable half-life.
Right. Most drugs follow first-order kinetics. The more drug you have, the faster your body eliminates it. It's a proportional relationship.
Okay.
Phenytoin is different. It switches from first-order to zero-order kinetics right in the middle of the therapeutic range. The liver enzymes that metabolize it, CYP2C9 and 2C19, they just get saturated. They're working at their absolute maximum speed.
So if you give even a small dose increase when those enzymes are already maxed out.
That extra drug has nowhere to go. It can't be metabolized, so it leads to the sudden, huge, disproportionate spike in the plasma concentration. The half-life can jump from, say, 12 hours at the low end of the therapeutic window to as much as 60 hours at the high end. This is why you have to monitor plasma levels. It's not optional. You have to keep it between 10 and 20 micrograms per mil, knowing that anything over 35 is severely toxic.
Given that risk, why did doctors use it for so long?
Because before the 1970s, it was one of the best non-sedating options they had for GTCS and partial seizures. It worked, but the cost was constant, vigilant monitoring.
Let's talk about that cost. The adverse effects.
The list is long. The common aesthetic ones are things like gum hypertrophy, that's an overgrowth of the gingival tissue in about 20% of patients, plus hirsutism and a coarsening of facial features.
And the more serious internal effects.
You have hypersensitivity reactions like rashes, a lupus-like syndrome, and long-term use can interfere with folate and vitamin D, leading to things like aplastic anemia or osteomalacia.
And the risk during pregnancy is a huge concern.
A major concern. It can cause what's known as fetal hydantoin syndrome, which includes things like cleft palate and microcephaly.
What about signs of an acute overdose?
Overdose usually shows up as cerebellar and vestibular effects. The cerebellum is really sensitive to it, so you'll see ataxia, a loss of coordination vertigo, nystagmus, which is involuntary eye movement, and then mental confusion.
And what about giving it intravenously?
The IV formulation itself is caustic. It can damage the vein and cause tissue necrosis. It has to be given very slowly with ECG monitoring. That's why we now prefer fosphenytoin, which is a water-soluble prodrug that's much safer to inject.
Okay, moving to the next classic pillar. Carbamazepine. It's chemically related to an antidepressant, right?
Yes, to impamine. And its mechanism is fundamentally the same as phenytoin's, prolonging that inactivated state of the sodium channels to prevent repetitive firing.
Is its dosing any simpler than phenytoin's tightrope walk?
It's simpler, but it has its own little kinetic trick, which is autoinduction.
Autoinduction.
So its absorption is slow and variable. When you first start the drug, its half-life is long, maybe 20 to 40 hours. But carbamazepine is a potent inducer of the very liver enzymes that break it down.
So it actually teaches the liver to get rid of it faster over time.
That's a perfect way to put it. Over the first few weeks, it ramps up its own metabolism, and the half-life drops to a much shorter 10 to 20 hours. It means the starting dose is different from the maintenance dose. It's dynamic, but it's less volatile than phenytoin's zero-order shift.
And what are the key adverse effects to watch for with carbamazepine?
Well, beyond the usual drowsiness and dizziness, there's a really specific and important one: water retention and hyponatremia, low sodium levels.
And that's because of its effect on ADH, antidiuretic hormone.
Correct. It enhances ADH action, making the body hold on to more water. This dilutes the blood's sodium content, which can be dangerous.
And clinically, where does it shine?
It is the most effective drug for complex partial seizures and GTCS, but remember, it's useless for absence or myoclonic seizures. And crucially, it's also the undisputed drug of choice for trigeminal neuralgia.
Okay, finally, let's talk about Valproate, the multi-tool drug.
Yeah.
It has such a broad spectrum because it attacks the problem from multiple angles.
Valproate is a powerhouse. It's a branched-chain carboxylic acid, and it has probably the most diverse mechanism of action of the older drugs.
How does it manage to work on so many seizure types, including absent seizures, where the others just fail?
It's a triple threat. First, it does the standard sodium channel inactivation like phenytoin. Second, it weakly attenuates the T-type calcium current, which is the exact mechanism ethosuximide uses for absent seizures.
And
third, it significantly boosts the inhibitory neurotransmitter GABA, both by promoting its release and by inhibiting the enzyme that breaks GABA down, GABA transaminase.
so it's blocking excitation and boosting inhibition at the same time.
Which is why it's so incredibly versatile. It's the drug of choice for absence and myoclonic seizures, but it's also highly effective in partial GTCS and atonic seizures.
And its use extends beyond epilepsy.
Right. It's used as an alternative to lithium for mania and bipolar illness, and it's also a common choice for migraine prophylaxis.
Given that potency, what's the most feared side effect?
The rare but very serious risk of fulminant hepatitis. It's especially a concern in very young children, under 3 years old. You have to monitor liver function like a hawk. Pancreatitis is also a risk.
And in pregnancy?
It's associated with a high rate of spina bifida and other neural tube defects. If it absolutely must be used, proactive folate supplementation is essential. It can also cause major drug interactions, displacing phenytoin from proteins and inhibiting carbamazepine's metabolism. It's a tricky one to combine.
Okay, here's where it gets really interesting for me. The drug development story moves beyond just hammering sodium channels. We start to see these highly specific drugs or ones that act on totally different systems.
This was a revolution. It offered hope for patients who were resistant to the classics, and just as importantly, it offered cleaner kinetic profiles. Let's start with the perfect example of specific targeting, ethosuximide.
The T-current specialist. It is the definition of a narrow-spectrum drug.
It absolutely is. Its mechanism is almost entirely focused on one thing: blocking the T-type calcium currents in central neurons.
And the T-current is that pacemaker current, right? The one that drives the specific rhythm of an absent seizure.
Exactly. It drives that characteristic 3 Hz spike in wave activity. By suppressing that specific current, you disrupt the seizure loop.
But it's only effective for that one purpose.
Only in absent seizures. It's useless for anything else. The upside is its side effects are generally milder GI upset, drowsiness making it much easier to manage than phenytoin.
Now, before we move on, we should give a nod to the oldest players, the barbiturates, phenobarbital and primidone.
Phenobarbital was the foundation. Introduced in 1912, it was the first truly effective anticonvulsant, a monumental breakthrough at the time.
But its major drawback is why we don't use it much anymore.
Yes. Its mechanism is potentiation of GABA, enhancing chloride entry into the neuron. It works. It's effective for GTCS and partial epilepsy. But the sedation, the cognitive impairment, that barbiturate hangover is just not acceptable by modern standards.
And primidone is basically just a prodrug for phenobarbital.
Essentially, yes. The liver converts it into active metabolites, mainly phenobarbital and another one called PEMA. Its uses and drawbacks are basically the same.
Okay, that brings us to the benzodiazepines, the BZDs. They are fantastic for stopping seizures, but primarily for acute intervention.
They are the fastest, most powerful way to boost inhibition. Like phenobarbital, they facilitate GABA action.
For longer-term use, the sources mention clonazepam as an add-on.
Yeah, clonazepam can be used for myoclonic and absence epilepsy, but its utility is limited because patients develop tolerance to the anticonvulsant effects pretty quickly. Plus, there's the risk of sedation and dependence.
But in an emergency, they are a lifesaver.
Absolutely. Diazepam is a first-line drug for acute conditions like status epilepticus or tetanus. The only issue is that it's extremely lipid-soluble, so it redistributes out of the brain into fat tissue very quickly. Its action is very short.
Which is why lorazepam is often preferred for status epilepticus now.
Exactly. Lorazepam is less lipid-soluble, so its action is much more sustained, maybe 6 to 12 hours. That prolonged effect is vital in an emergency. The risk with both, especially Rauvi, is significant respiratory depression.
Now we enter the modern era, starting with lamotrigine. It seems to combine the efficacy of the classics with a much cleaner profile.
Lamotrigine is a great example of refining an old idea. It works a lot like carbamazepine and phenytoin, prolonging the inactivated state of sodium channels and suppressing glutamate release.
So its clinical utility is broad spectrum.
Very. It's a first-line drug for partial seizures and GTCS, but it's also effective for absence and myoclonic seizures. It's a great option for patients with multiple seizure types.
Does it have the same kinetic problems as the older sodium channel blockers?
It avoids the zero-order kinetics, which is great, but it does have a critical drug interaction. Normally, its half-life is about 24 hours, but if you combine it with Valpro, which inhibits its metabolism, that half-life can double, risking toxicity.
And the big safety alert for lamotrigine is the need for that slow titration.
This is non-negotiable. You have to increase the dose very, very gradually over weeks. This is done specifically to minimize the risk of a severe, potentially life-threatening rash, including Stevens-Johnson syndrome. The benefit is worth it, but you have to respect that titration schedule.
Okay, next up are the so-called GABA analogs, gabapentin and pregabalin. But that name is a bit of a misnomer, isn't it?
It's very misleading. Gabapentin is a lipophilic derivative of GABA, so it crosses the blood-brain barrier easily, but it does not act as a direct agonist at GABA receptors.
So if it's not plugging into the GABA receptor, how does it work?
It binds to the alpha-2 delta-1 subunits of voltage-sensitive calcium channels. By binding there, it modulates the channel's function, which decreases calcium influx into the presynaptic terminal.
And less calcium means?
Less release of excitatory neurotransmitters like glutamate. It's a presynaptic depressant.
Which explains why it's found such a huge role outside of epilepsy.
Exactly. It's used as an add-on for refractory seizures, but its biggest use is for neuropathic pain and generalized anxiety. Its good tolerability is a huge plus.
We should also mention vigabatrin, which is a true GABA intensifier.
Right. Vigabatrin has a very clear mechanism. It irreversibly inhibits GABA transaminase, the enzyme that breaks GABA down, so it just increases the amount of inhibitory GABA in the brain. It's used for really severe cases like infantile spasms.
But there's a major trade-off.
A very serious one. It's associated with irreversible visual field contraction. Because of that risk of permanent vision loss, its use is heavily, heavily restricted.
Okay, finally, let's turn to the truly unique mechanism, starting with levetiracetam. This is the drug that targets a specific protein inside the cell.
Levetiracetam is fascinating. It doesn't fit any of the classic molds. It works by binding to a protein called SV2A, synaptic vesicular protein 2A.
What does SV2A do? And why does binding to it stop seizures?
SV2A is found on the little sacs, the vesicles that store neurotransmitters. It's thought to regulate how those vesicles fuse with the cell membrane to release their contents. By binding to it, levetiracetam seems to modulate neurotransmitter release, mainly by inhibiting excessive glutamate release.
And the clinical benefit of this unique mechanism is massive.
It's huge. Its broad-spectrum works for GTCS, partial and myoclonic seizures, but its biggest asset is its kinetics. It's mostly excreted unchanged by the kidneys, which means it has virtually no significant drug interactions.
That simplicity is revolutionary compared to the classics.
It's a huge relief for clinicians.
Next, the drug with 4 distinct mechanisms. Topiramate.
Topiramate is an incredible multitasker. It hits 4 targets: sodium channel inactivation, GABA potentiation, antagonism of glutamate receptors, and the really unique one, carbonic anhydrase inhibition.
That last one feels like it comes out of left field.
Yeah.
How does blocking that enzyme help?
Carbonic anhydrase helps regulate pH balance in the brain. Inhibiting it can cause a slight shift in that balance, which in turn helps to dampen down neuronal hyperexcitability.
And clinically, it's broad spectrum, but it's also well known for migraine prophylaxis.
Yes, but that carbonic anhydrase inhibition is also responsible for its most common side effects: paresthesias, that pins and needles feeling, and an increased risk of kidney stones. It also often causes weight loss and cognitive slowing.
And finally, zonisamide also has that carbonic anhydrase link.
It does. It's a sulfonamide derivative that blocks both sodium and T-type calcium channels, but it also gets some of its effect from that carbonic anhydrase inhibition. It's used for refractory seizures, but you have to watch for somnolence and, again, the risk of renal stones.
We've built up this extensive arsenal of tools now. So this raises the big question. Knowing all these individual drug profiles, how does a physician actually navigate this complex decision tree? And what happens in an emergency?
That's the critical part. And the hard truth is that total seizure control is only achieved in about half of all patients. For the other half, it's a constant balancing act.
Maximizing control while minimizing side effects.
Precisely. And the approach is standardized. First, the choice of drug is dictated entirely by the seizure type, and you always start with monotherapy, single drug, at a low dose.
And you gradually increase it until
either the seizures are controlled or the side effects become unacceptable.
So you don't start with a combination of drugs.
No, that's reserved for when monotherapy fails. And if you do need to combine drugs, the smartest approach is to pair drugs with different mechanisms. So a sodium channel blocker with a GABA enhancer, for example. Combining two drugs with the same mechanism often just doubles the side effects.
Let's quickly recap the first-line recommendations from the sources for the major seizure types.
Okay. For partial seizures, simple or complex, the first-line choices are carbamazepine, lamotrigine, and valproate.
And for generalized tonic-clonic seizures.
For GTCS, the preferred drugs are valproate, lamotrigine, and carbamazepine. Very similar list.
But for absent seizures, the choice is much narrower.
Much narrower. You need that T-current targeting, so your choices are valproate or ethosuximide.
And for myoclonic or atonic seizures.
There, you favor the broad-spectrum agents that boost inhibition. Valproate, lamotrigine, and levetiracetam. You can see how valproate, because it hits so many targets, shows up as a first-line choice across the board for generalized seizures.
Okay, let's shift to the emergency room. Status epilepticus. This is where rapid, aggressive intervention is absolutely mandatory.
It is the most dire medical emergency in epilepsy. It's defined as seizure activity going on for more than 30 minutes or 2 or more seizures without the patient ever regaining consciousness in between.
So what's the first priority?
Airway. First and foremost, you maintain a patent airway and ensure they're breathing. The next immediate step is to give IV dextrose to rule out hypoglycemia as a cause.
And then the drug protocol begins.
Yes. Lorazepam, 4 milligrams thesaba, is the first choice, specifically because its effect is more sustained than diazepam's. If that doesn't work after 10 minutes, you can give another dose.
But the benzodiazepines are just to stop the immediate seizure, right? They don't provide long-term protection.
Exactly. After you've broken the acute seizure, you have to load a long-term maintenance drug intravenously to prevent it from starting again. This is typically phenytoin or fosphenytoin, given as a slow 5E infusion.
With ECG monitoring.
With continuous ECG monitoring, though now IV valproate or levetiracetam are also being used more often to avoid the cardiac risks of IV phenytoin.
And what about febrile convulsions, the seizures that happen with high fever in kids?
They're generally benign, but absolutely terrifying for parents. The focus is on reducing the fever with antipyretics and cooling. If the child is actively convulsing, the standard treatment is rectal diazepam.
And we don't use chronic prophylaxis for that anymore.
Not for simple febrile seizures, no. The risk of side effects from daily drugs like phenobarbital just outweighs the relatively low risk of them developing long-term epilepsy.
Finally, the very sensitive issue of pregnancy and AEDs.
This is a really complex balancing act. We know most AEDs increase the risk of birth defects. So the mandate is, first, do not abruptly stop the therapy because that puts the mother at high risk for status epilepticus.
And second,
attempt to reduce the dose to the absolute minimum effective level. And if possible, substitute high-risk drugs like valproate with a safer alternative, like lamotrigine.
And you supplement with folic acid.
Aggressively. High-dose folic acid throughout the pregnancy to reduce the risk of neural tube defects, and then vitamin K in the last month to prevent bleeding disorders in the newborn.
So what does this all mean? We've taken this deep dive through the electrical chaos of epilepsy and seen how treatment is just this delicate molecular balance. Successful therapy really hinges entirely on correctly classifying the seizure, doesn't it? From the chaos of a GTCS to that specific pacemaker current of an absent seizure.
And matching it with a drug that has the right mechanism and a clean kinetic profile. The whole journey shows this move from volatile capacity-limited molecules to agents that offer almost surgical precision.
And that tension between old and new is driven almost entirely by pharmacokinetics.
Right.
We talked a lot about how phenytoin's metabolism is capacity limited, how the liver enzymes get saturated.
Right, and how a tiny dose change can suddenly push plasma levels into the toxic range. That switch from predictable first-order to volatile zero-order kinetics.
That volatility is shared by phenobarbital, carbamazepine with its autoinduction, and valproate.
All the classics have their kinetic quirks.
So, given how critical it is to monitor plasma concentrations for all these narrow therapeutic index drugs, what broader implications does this concept of enzyme saturation have for dosing any critical life-saving medication?
And to flip that around, should we view the arrival of these highly tolerated drugs with simple, non-hepatic elimination like levetiracetam, which just bypasses that saturation risk entirely, as the ultimate standard of pharmacological safety?
Even if we don't fully understand its complex mechanism of binding to SVD and CA.
Exactly. It's something to mull over as you compare the inherent risks of a precision mechanism versus the safety of predictable clearance.